Thank you to the organizers and the chairperson. So I'll discuss something more on the topic, which is I think something which we try to neglect. That is called cancer cachexia. Very specific. I'm talking about cachexia related to cancer and anorexia, which are both altogether same. So there's a definition for cancer cachexia. It's a multifactorial syndrome, which is characterized by ongoing loss of skeletal muscle with or without the loss of fat that cannot be fully reversed by a conventional nutritional support and leads to progressive functional impairment. So I think this is create. Yeah. So the important thing is anorexia is also part of it. Anorexia is loss or absence of appetite, leading to reduced caloric intake, resulting in the loss of weight and the fat tissue. Remember one thing: cancer cachexia is not reversible and may not correlate with anorexia. They can coexist or they might not be part of the same. So there is a syndrome called CACC, which is also known as syndrome of cancer anorexia cachexia syndrome, which is a complex multifactorial metabolic syndrome, which has got this anorexia, cachexia, asthenia, fatigue, and the change in the body image is part of it. Lots of definition, lot of criteria has been going on for the last 15-20 years. One of the first definition which came was in the around 2001, 2011 I will say, which looked at the diagnostic criteria. They said that any weight loss of more than at least 5% in 12 months or less, that is, or a BMI of less than 20, and add 3 or the 5 things from the next 5 findings, like decreased muscle strength, fatigue, anorexia, low fat free index, abnormal biochemistry. This biochemistry looked at hemoglobin, serum albumin, and the inflammatory markers. So that is how they used to classify the definition of cachexia. They have given a definition for fatigue also, anorexia also, and they try to look for this low fat mass index through the mid arm, upper arm muscle circumference, and also for the gender and other issues. But the overall period of time, the definition has changed. Now, the latest definition is very simple. The criteria for cancer cachexia is weight loss greater than 5% or weight loss greater than 2% in individual already showing depletion according to current body weight and the height BMI, which is less than 20, or a skeletal muscle loss, so sarcopenia. So I'll just put up a lot of things in the next few slides, how to differentiate sarcopenia, starvation, and the your cachexia. So experts nowadays are very clear that instead of defining too much, giving too much importance to definition, you should try to put them into a stage we call pre-cachexia, cachexia, and refractory cachexia, which looked at the severity of nutritional depletion. So this is how it looks like. You have 3 stages called pre-cachexia, cachexia, refractory cachexia. Pre-cachexia is one which is most important because here the intervention will matter a lot. You have a weight loss of less than 5%, but you have anorexia and metabolic change. Cachexia, where you start losing the weight more than 5%, BMI is less than 20, weight loss more than 10%, or sarcopenia, or the weight loss, or sarcopenia and weight loss more than 2%. And they are often characterized by decreased food intake and the systemic inflammation. Refractory cachexia is where your survival is less than 3 months and you have variable degree of cachexia, cancer disease, both pro-catabolic and responsive and not responsive to any kind of anti-cancer therapy. So in order to define this classification, 5 domains needs to be assessed. You have this anorexia, catabolic drive, you have this stores depletion, which looks into the fat area, muscle mass and strength, and function and psychological impact. But due to lack of any formal validated cachexia assessment, most of the time we look at only malnutrition assessment, which can be easily checked. So when you define how to differentiate sarcopenia from cachexia, cachexia is distinct from the sarcopenia, which is defined specifically based on the loss of skeletal muscle mass, often by 2 standard deviation below the specific sex age and the age registry value. Whereas most patients with cachexia are sarcopenic, most sarcopenic patients are not considered cachexic. So muscle loss without the loss of fat is known as sarcopenic obesity. A different term, I'll just put up a photograph for it also. The cause of sarcopenic obesity is something which we should be very aware of it. The causes of sarcopenia also multifactorial. But remember, when we treat as a medical oncologist, there are 2 drugs not only two drugs, there are many TKIs which tend to create this kind of sarcopenia. Many times we attribute that this is nothing but disease progression, but it is sarcopenia. Most notably, it is the sorafenib, and also and our most of the treatment for our prostate cancer, androgen deprivation. So this is how you differentiate the starvation from the cachexia. Remember one thing, there is something known as visceral muscle and skeletal muscle. You have in starvation visceral muscle loss, but in and also loss of fat. Starvation basically leads on to mostly loss of fat and the visceral muscle, whereas other things are more lost in the cachexia. Prevalence is very high prevalence, around 26% of the patient, palliative patient, 66% of patient who are already cancer patient, and most commonly naturally in the elderly. And the main cause of death in more than 20% of patient is cachexia. So there are certain tumor sites which are more related to cachexia. Naturally, we have all this GI related thing and head and neck. So they are the topmost. So like pancreas, gastric esophagus, and the head and neck, they are then the where the incidence of weight loss or cachexia is very high. Like I said, there are certain things which are important. People looked into the pathogenesis because based on the pathogenesis, you are supposed to try to give some treatment. One of the most common cause is your hypercatabolic state, which is related to, like it can be related to cytokines, inflammation. So we use a lot of common term we call resting energy expenditure. It's nothing but a basal metabolic rate. In most of the patients who are cachexic, they have this increased REE, and they found, like one of the series, they found nearly 74% patient had a very high resting energy uptake, nearly 74. Because of their ability to increase the resting energy expenditure and induce anorexia, a lot of factors have been thought about. Like you have this TNF alpha and interleukins, but it's not always correlated. So that's why we say that even though cytokines have been part of the thing, but they are not always only cause. So it's a multifactorial. Like this in this photo, it has been shown that cytokine affects the brain, which leads on to anorexia. Most important thing, it affects the skeletal muscle, leading on to increased amount of protein loss and the less amount of protein synthesis, since it is a catabolic state. And some of the cancer, they have found that the protein loss is nearly more than 240%. Also implicated is this tumor produced lipid mobilizing factor, which may also contribute to the wasting like phenomena. Other pathogenesis factors which are part of the protein pathways are the ATP ubiquitin, JAK2 stat. Why all these things have been elucidated? Because based on this, some drug has been part of the theory. Now, but the latest thing is genomics. Now they are trying to find that only certain patients only they do suffer. So there might be some abnormality with some particular type of interleukins which are getting activated in some patients. But I think something which we should not forget is secondary inflammation. You have dysphagia, you have pain, depression. Many times because of depression they stop eating, and anorexia related to your anti-cancer therapies like mucositis, nausea, vomiting. And the most important thing which I have not mentioned here is dysgeusia. The taste sensation is something which is a culprit of most of the time leading on to cachexia or sarcopenia. So clinical characteristic, changes in body composition. Body composition matter more than the weight. That's very important, and that's the reason why when you are trying to look into how to measure cachexia, one of the thing is you can do a standard CT, which is just been done for the routine cancer care. So nowadays people do this augmented segmentation of axial lumbar CT images, which will give you an idea about the kind of muscle and the adipose tissue. Like in this graph, this photo, it has been shown. So they divide the adipose tissue into three different type of adipose tissue. We call it visceral, subacute, and intermuscular. On the left hand side, if you see, on the left hand side you have a very big muscle mass, very less amount of visceral and your intermuscular and subacute tissue. Extreme right, you can see the whole thing, even though the patient is looking very obese, but they have hardly any muscle mass. So they are something known as sarcopenic obesity. So alteration do happen in the nutrient metabolism. Many times we have tendency have that cachexia patient have got a very high sugar. We go on giving insulin because they have a tendency of hyperglycemia, hypertriglyceridemia. I think that's one of the reasons why we always say in palliative care patient never be very aggressive in trying to do lipid testing and all doing all this sugar testing. Body composition matters a lot because it leads on to the it predicts the toxicity. It is a bad prognostic sign. Weight loss, cachexia, everything is part of the poor, high chance of getting hospitalization and death. All cancer patients should be assessed for nutrition status and weight loss, that is a criteria, and clinical assessment should try to look for which are the secondary cause factor which are looking at the decrease in the nutrition status. And physical examination is very important in any patient, because you have to look for area where you have the muscle wasting, and also try to look into the hand grip. Hand grip is very important. It gives you an idea about a simple way how to check your how much is the muscle strength. But yes, the first thing, look into the weight loss. Nutrition screening, there are a lot of parameters, a lot of questionnaires which help you out, lab parameters, in-depth nutrition assessment with certain things, but only when you are very planning to be very aggressive. Like in a refractory cachexia, there is no point of being very aggressive in doing all the CT scan. In a cachexic patient, fine, and pre-cachexic also fine, but in a refractory cachexia patient, better to avoid all those things. So you have two types of therapy, pharmacological and non-pharmacological. You have three different types of drugs. For pharmacological, we call appetite stimulants, anabolic agents, cytokine and metabolic inhibitors, and non-pharmacological, we have two things called exercise and dietary. So orexogenic drugs are there. The most important commonly we use is steroids, corticosteroid, progesterone analogs, cannabinoids, and serotonin antagonists. The primary benefit with these drugs are increased appetite, modest weight gain, and no improvement in the survival and quality. And where you are expecting a longer expectancy, the one of the drug which we commonly use, NDAs and MIGAs, is more appropriate, but potential side effects you have to remember with the balance with the risk. Cannabis, cannabinoid, in my private practice nowadays, every third patient in the palliative care is taking marijuana. It's very easily available. It's a WhatsApp group drug which is easily available by everyone. But yes, studies have not found any kind of association that it improves your appetite or weight gain. Cyproheptadine only in a patients who have this carcinoid syndrome, it is helpful. In other cases, it is not helpful. Androgens, lots of androgen we used to use, but rarely nowadays. And there is a drug called aminoreline, which is a oral renin mimetic, has been promising, but a data has come with the Romana 1 and 2 trials, which have basically, they have shown that it increases the body weight and lean body mass, but the effects are only modest. And also it is not commercially available also, and did not improve the overall survival. So these are the new drugs which are part of it. You have this bimagrumab, ruxolitinib, which is a JAK2, not found to be any useful at all. Enobosarm, which is also been phase 3 data has been completed, not too much useful also. Other drugs like icosapentacetate, thalidomide, not have been found to be useful. So just to summarize about this pharmacology agents, most trials are small, difficult to generalize. Bottom line is there is no great treatment at this time. Lots of ideas, and lots of ideas and theories, no and great result. Nutrition care plan, this is a ESPN guideline. I think lots of talk must have gone about how much amount of protein intake we need to increase, how much calorie we need to increase. The bottom line is very clear that nutrition therapy, it improves the body weight, but not survival. It's useful only in the pre-cachexia and the cachexia state, not in the refractory thing. And when you give both combination with the dietary advice and oral supplement, may be more effective. And short-term nutrition support, there is no need. And also I think lots of topic has been regarding glutamine. To my knowledge, there is no evidence, and no evidence supports that nutrients feed the tumor. So role of EPA, controversies, lots of things. Evidence is very weak. 3 systemic reviews which have been conducted over last many years do not support any recommendation that 2 gram has to be given for it. So exercise is also one thing. So there is a study going on which is trying to look into the criteria where multimodality works well. So just to conclude, the step approach should be to recognize cachexia earlier, that is our thing, refer and collaborate, refer to a nutrition person and to a psychologist. Exercise makes a lot of importance, but the most important thing is the empathizing, how to reframe the word and explore the thing. There is no standard trial. And like I say, you have to just go with a 3-way of treating the patient. Target the tumor, most important. Target the secondary nutrition impact syndrome. And lastly, target the muscle wasting. Thank you.